And I'm going to go through this today now. We're going to look at the case record, and what I'd like you to do is to write in the sidebar what your comments are in relation to what we could pull out in the case that we're going to discuss. Fen learning, if you want to make some comments as you're going along, that would be lovely. So we'll go to the first slide now. Is it going to move? Let me move down. Yeah, okay. And I'm going to try and do this in real time for you. So what I want you to imagine here is that this is a patient record, that you've looked after the patient or somebody else has. There's no reason why you couldn't reflect on somebody else's work. And they've completely anonymized this record, but the record has been authenticated by another. So Lucinda James, who's an emergency care practitioner, has signed to say she's seen the original card and she's dated it, and that this is a true copy of that card. So all the patient's details have been removed, the hospital and consultant details, the date, the time, attendances and entries have been removed, because believe you me, I've done it before now where I've traced a patient back from an anonymized record and been able to look at the x-rays of the patient, okay? So just be wary of that. And the other thing is if you've got any bars on there that you recognize the patient, the scanning bars, then they should be removed as well. I can't see the comments bar, so I'm going to have to rely on my Fen board colleagues to tell me what's coming up and what we can put in. So looking at this case, this is written, the triage wasn't done by the originator of this, but you can still make comments on it. So when you look at it, what do you think of this record? And remember, you're trying to pull out what's good and what's bad in it. I'll give you a couple of minutes to look through it. Have we got anything in the sidebars, John? John, are you there?
Yep, no comments.
No comments, nothing coming through at all. Okay. People don't want to play with me. All right. Okay, so what we're going to do is we're going to need to have a call out so that we can talk about what we see in here. So here we've got a call out on a patient, and we know that this is an 83-year-old, and I should have added lady in there, but that's a mistake there. So if I go to remove the shape fill, I can then type in there. So you can write in here the age, oops, oh come on, why is it not working now? Age of patient important, yeah? Because, yeah, there's all the risks of being older and having a head injury. And you would probably go into more details and start to discuss those. So I've done an opener. Can anybody else come up with anything different?
So from Emma, loss of consciousness with head injury, red flag.
Okay, great. So if I make that smaller. So where do you know that from? How do you know that a loss of consciousness in a head injury is a red flag? Who says it is?
From Emma, local ED guidelines.
Okay.
Gillian, Menstrual triage.
Okay. So we've got a few pointers there, haven't we? So what you
Jean,
could...
nice.
Okay, great. Fab. So what you can do is you can pull out that further. You can start to discuss that. You can start to go into details and get the depth of why is that a red flag? And what is the variance in somebody who's 83 compared to a 24-year-old? Yeah. And remember that you've got to reference this in the same way as you would do any university work. You need to reference it, because otherwise it's plagiarism, and plagiarism isn't allowed. If it isn't your original thought, then you need to say where you... Any other comments coming out?
From Gillian, use Manchester triage. I think we've done that.
Yeah.
Yeah, nice. From Chris, hypertensive. Why is she hypertensive? Does she have a history of BP related issues?
Okay, fabulous. So where we got the BP here? Oh, it's
From Kay,
isn't
she
it?
says silver
Hold on.
trauma guidelines. From Kelly, confusion, lower GCS, nice guidelines for CT.
Yes. So hypertension, why? Yeah. And then from here, it was the silver guidelines as well, wasn't it?
Yeah. And from Nia, asking, is the confusion new?
Great.
Dorianne says, fall from standing in someone over 65 years old is significant. Mechanism of injury with the MTS guidelines.
Yeah. Now then, how would we...
Gillian says there's been a drop in the GCS, and Jean says, what is 90/60 in presenting complaint?
Okay, that I can tell you is a way of documenting how many minutes it is from the time of injury. So the 60 represents the minutes in the same way as you have 7/52 representing weeks, or 1/12 representing months. Something over 60 is the number of minutes, and 1/24 is an hour.
Yeah, Chris is saying just be careful over that, because you can mix that up with a systolic. Emma says issue on anticoagulation.
Yeah, brilliant. And what was the last point we raised? I've forgotten to write it down.
Just a minute. MTS guidelines, silver trauma.
No, we've got that.
Drop in GCS. Fall from standing in someone over 65 is a significant mechanism of injury. Okay. MTS guidelines.
Yeah, that's the drop in GCS, you said.
Yeah.
Yeah.
And Sam says vomiting, sign of possible concussion.
Yeah.
Chris just saying he's never seen that abbreviation for time. Leanne, it was an unwitnessed fall as the son found his mum. It may have been a collapse, not a fall.
Yeah, certainly can. Yeah, brilliant.
Kay suggests it's a severe she's got a severe headache and heart rate's over 100, so it's significant.
Yeah. So each of these things that you're picking up are bullet points. But what you can do is you can develop the argument of why they should happen, why they're significant. So you're taking the detail, the depth of the detail there. Now, should you want to reference any of these, like the silver guidelines, are they nice, or are they ARChem, the silver guidelines, aren't they? Have I got it wrong? Isn't it ARChem silver guidelines?
I'm not sure. It's definitely the silver handbook.
Yeah.
ARChem.
ARChem.
From ARChem. From ARChem.
Yeah, so what I'd reckon that you should do here, rather than put in Archem, because you haven't got a lot of space on this page, then what I would do is I would use the numbering for being able to reference. So you'd go and you'd make it a super strike one, so it's going up, and then in your reference list it would be number 1 that you would do. Yeah, now the other thing I should say to you, I'm doing this on the computer, but you really don't need to. As long as your handwriting is good and people can understand it, it's fine to do this in handwritten. You don't need to learn computer
Anna
skills.
says no mention of neck pain. And
Okay.
Kay points out that it's not just Archem, the Hector course mentions the Silver Trauma Guidelines.
Okay, fab. And Silver Guidelines. So there's an awful lot of evidence coming up here, isn't there? What else can we bring in here? Drop in GCS, we've said about the nausea, possible concussion. What else? Obviously, all of these would be a separate box rather than them all being in one, unless they really were related.
Judith, did you get the suggestion of no neck pain there? Because I think that's a really important point.
It certainly is.
Yeah.
Yeah.
Okay. Hannah said that, and I think that's really, really vital.
Okay.
Yeah.
Andrea is saying, is there any laceration to the head?
Fabulous. I'd always be careful of using the word laceration because it tends to mean a sharp wound. So I always use the term wound rather than, and that's what we teach when we are teaching emergency nurse practitioners, to use wound rather than it being incisional or laceration. Sorry, laceration isn't a sharp wound, it's a blunt wound.
Jan says severe headache, that's an MTS guideline. Gillian says she's got a slightly raised respirate. Jean says walked into the department, does she need to see spine precautions? Chris said, could the severe headache be a distracting pain regarding a neck injury?
That's a really valid point. And severe headache for neck pain. Okay. Anything else?
You could assess her walking. So is she leaning to one side? How is she walking? She's walking unaided at the moment.
Okay. So you're talking about the gait, yes?
Yeah.
Okay. Anything else?
Emma says, any other neurological deficit? Someone who hasn't put their name on, just that it's from their iPhone. Any previous attendances? Any thought that she might be being abused by someone? Any falls risk? Elizabeth says, have you checked the pupils? Chris says, could you be alert and confused? I think the answer to that, Chris, is the research guidelines would suggest you can't be both. You're one or the other. Jean says
Hold on a sec, I'm missing a couple there. So I've got falls risk pupils, we had safeguarding, didn't we?
Yeah. Previous attendances, any information in that?
Yeah.
Any other neurological deficit?
We got that one down, I managed to capture that.
Jean says you've written down brought into department without further information. What other information is needed from a triage point of view?
Okay. Anybody like to elicit anything on that? What other information you'd want from triage?
Various things that people would like to suggest.
Okay.
So there's any symptoms prior to a fall or collapse, any seizure activity, past medical history. A couple of people suggest medication history. Another suggestion of past medical history. Does she live alone? Pain score. Someone else saying wouldn't expect much more except a coagulation history. Caroline says there doesn't seem to be a discriminator, so to say why she's category 2.
What, as a general consensus, how many of you would put a discriminator there saying that she's priority 2? Or would anybody disagree that she's a priority 2?
A couple more comments, but not about that question.
Okay.
Came home by ambulance. Did they give her anything? And we thought about her allergies.
No, she didn't come by ambulance. Her son brought her because there was a problem with the ambulance, wasn't there? So he brought her in her own car.
Okay, so we now have a stream of comments that new confusion would make her category 2.
Yeah.
I agree. D2, head injury with reduced GCS and loss of consciousness. Agree. New altered GCS under 24 hours. From MTS, it should document discriminator P2 likely to altered consciousness. Everybody agreeing. P2. I think she'd hit P2 with Manchester triage flowchart. Altered GCS, new, orange. I agree she's priority 2, but discriminator assures us as to why we chose priority 2.
Okay. Fabulous. Okay. Is there anything else we want to pick up on that slide before we go on to the next set of notes? There's an awful lot of information there that you can pick up on and you could write about, and you could take that learning further. If you were talking, and you might not have enough room on the page, obviously this is bigger text because it's at a size 14, but if you could drop it down to a size 10, it will give you more room to write something. But equally, if there was something you wanted to go more into depth of, such as discussing the Glasgow Coma Scale, then you could add it as an addendum to the piece. So a separate box on a different slide itself, where you can discuss certain points, and you could have addendums 1 to however many you needed to do. But here what you're trying to do is demonstrate the integration of the work. So here we go to the next sheet now. So see what you reckon to this. So any comments coming through of what we think here?
Nothing yet. Okay, Warfarin, CT head.
Okay.
From Gillian.
Yeah. Fantastic. Okay, anything else?
Chris says amnesia. Sarah.
Yeah.
Sarah,
I can't spell either.
there's head.
Sorry, Jeanette, you're waking up.
Sorry. Injury with vomiting ×2. Increase blood pressure.
Sorry, Jeanette, I can't hear you. You're breaking up.
You hear me?
No,
Okay.
you're a
Without the headphones.
Dalek.
Can you hear me now?
No, you're a bit of a Dalek.
Oh dear. Right.
Claire, can you take over for me? Please, sorry.
Can you hear me now, Judith?
I can.
Switched on and switched off. Oh, there you go. Switch it on and switch it off again. Always works.
Okay, all
Gillian
right.
says, increasing respiratory rate and blood
No, you've gone again completely.
on again.
Yeah.
No.
Okay, Gillian says respiratory rate.
Increasing.
Sorry, I missed it.
So from Gillian, respiratory rate and BP increasing.
Thanks,
And what does that mean?
John.
Yeah. What
From
does the
Chris, we've got no analgesia, but pain increasing. Should give some simple analgesics.
And what are you going to give because she's vomiting?
From Kay, we've got multiple indicators for CT following NICE guidelines: warfarin, amnesia, vomits, and lower limbs for elderly.
Yeah.
Lower limits for elderly even.
Yeah.
From Jenna, head injury, new onset of confusion, warfarin, needs CT head, and BM.
Yeah.
Emma on warfarin, needs CT head.
Great. So we're all in agreement. She needs a CT head. Anything else coming out?
From Jean, collapse, history AFib, no ECG taken.
Okay, so she needs an ECG. She not had one done?
And Emma needs ECG.
She not got one anywhere? No.
Hannah, adequate analgesia. Alison, analgesia.
Yeah. Okay. What else? Here we go. Look, somebody mentioned the wound. Did she have any wounds? She's got a wound to the back of her
Mary,
head.
antiemetic.
Okay.
Alison, regular neuroobs.
Now, I hate that word. What does regular mean?
Regular.
Regular could be once a month. It could be once a week. They're still regular. But
Alison
what do
says
we mean?
hourly.
Hourly.
Kay says, is the bleeding controlled? Query dressing.
Okay. Are we sure that these are hourly? What do the NICE guidelines say about head
From
injury?
Sam, examination for other wounds and injuries when changing into gown.
Okay.
From Gillian, 30 minutes due to GCS drop.
Yeah.
Jenna, half hourly for 2 hours, hourly for 4
Yeah.
hours, 2 hourlies thereafter. Kay, 30 minutes, GCS less than
Okay.
15.
Looking
Hannah,
at
consider urgent transfer if in an MIU, not ED.
yes. In relation to the head injury guidance, does it also say that if they're elderly, then you should do them for a bit of a longer period? If they're elderly, that you shouldn't have them so tight.
Chris, we've got in care plan states 30-minute neuroobs, should be on 30-minute neuroobs until GCS returns to 15.
Yeah, okay. And there's a limit on that. They have to be at 15 for a certain period, don't they? So I think that was at 15 for 2 hours. But with the elderly should be a bit more. Okay, so what else do we need in there? Should we have put that in to the patient's care plan that they needed to be half hourly until 2 hours after the return to normal?
Gillian in elderly would continue 15 to 30 until GCS improves.
Okay.
From an iPhone and tetanus status.
Yeah, tetanus status is missing. What else?
Neuroobs, it says flush saline given under PGD. What does PGD mean? Also, urgent help requested. What help? Does this need to be more specific?
Okay, a PGD, it means it's a patient group direction, and in the UK, I don't know who asked the question, it means that you can give it without a doctor's prescription under a tight protocol that you've had training for. So not all the drugs have to be prescribed by a doctor or an independent prescriber. Yeah, so query what does. Okay. Anything else we're picking up from here?
Fiona, in Ireland, it's a delegated drug protocol.
Okay. And is that shortened, Fiona, to DDP or something?
Tanya asks, why is she hypertensive?
Okay. Anybody got any reason why she could be hypertensive?
Andrea says VBG as an early biochemical situation, including lactate. From Galaxy, INR blood investigation, query low HB. From somebody's iPhone, careful with maxilin in the elderly, consider alternative antiemetic.
Okay.
Gillian said could also include paracetamol as a basic if not had already.
Okay. Anything else?
Jenna, increasing BP due to bleed, query. Emma,
Yeah.
ICB causing hypertension. Caroline, query hypertension, query due to pain, query raised ICP.
Yeah.
Kay, history of hypertension but could be related to a cerebral injury. And Alison, past medical history states hypertension.
Fantastic. Okay. Is there anything else anybody would pick up? If this was your case, is there anything else that you'd like to see picked up? Oops, sorry.
Andrea, she could have vomited the ramipril, hence high blood pressure.
Yeah.
Gillian, there's been a further drop in GCS.
Okay. It's interesting that nobody has said anything about her nursing care when we nurse
Galaxy, CT scan to rule out bleed.
it.
From Caroline, it says condition worsening. What does that mean? Possibly needs to be more specific.
Okay.
Mary, reassurance.
Yeah. We've got some of the care there, haven't we? She's vomiting, they're giving mouthwashes, she's having essential care as required. We've determined, haven't we, somewhere that she wasn't at risk of a pressure sore at that particular point because she's walked in, but we don't know if she's been on the floor and hasn't had one. So pressure sore should be checked for.
For Gillian, what degree is the bed rest at?
Yeah, okay. So what would you put it at? Any other comments?
Elizabeth, 45 degrees.
Okay,
Hannah,
brilliant.
no more than 35. Tanya, 25.
5.
Gillian, we do around 30 degree or less. Sarah Edmonds would like a body map. Kay says 40 degrees. Chris, would you consider urinary catheter to reduce discomfort? Query need to mobilize. Backrest at 30 degrees.
Okay. So what's the consensus? We've had everything from 30 degrees to 45 degrees. What's the consensus on that?
Jenna, query 30 degrees if you're considering a bleed. Caroline, 30. Emma, 30. Chris, 30.
Okay.
Galaxy A20, Datex for pressure sore.
Okay, brilliant. Anything else? Let's go down to the final page then. Let me do it. So what do we get from here now? Oh, I wonder where they came from. Any comments coming through?
Jenna, airway concerns. Jean, seizure.
Okay,
Galaxy A20, admission for observation and treatment.
okay. Run that by me again, John. Airway concerns.
Airway concerns, seizure, admission for observation and treatment.
Okay. Anything else coming through?
Chris, no record of discussion regarding respect or DNA CPR.
Okay.
Sam, plan for level of care and query DNAR.
Yeah. Okay.
K, maintain comfort and dignity. Has DNAR been discussed?
Okay.
Galaxy A20, treatment for INR results.
Anything else?
Sam, have family been kept informed?
Okay.
Emma, spiritual care discussed with next of kin.
Okay.
Gillian, moved onto a bed in the department for comfort. From someone's phone, patient's wishes.
Yeah.
Chris, chaplain attended, so likely spiritual needs were met.
Sorry, Chris said what?
Chaplain attended, so likely spiritual needs were
Yes.
met.
Yeah.
Dorian, palliative contacted. Hannah, possible organ donation.
Yeah.
Mary, in current climate, PP requirements for family.
Yeah.
Andrea, to be made comfortable means position or syringe driver was also given. Jean, nursing diagnosis to structure nursing care. K, is there a quiet space for patient and family? Does the department use a symbol to ensure other staff are aware of need for respect in the area? From somebody's phone. ID wristband, formal ID with police after death.
Yeah, and symbol for peace. Yeah, and police. Yeah. Okay. What else?
Chris, query involvement of palliative care team.
Okay, we've got
Um,
palliative care there, so query. Yeah.
From somebody's phone, patient's dignity.
Yeah. Okay. Anything else that anybody can think of?
Dorian, create debrief for staff.
Sorry, debrief for staff.
Gillian, preemptive prescribed.
What does that mean?
Is that anticipatory medication?
Sorry, Jeanette?
Anticipatory medication.
All right, okay. Okay. Anything else?
Tanya, end-of-life pathway. Gillian, things like morphine, hyoscine, etc. Kay, tissue donation discussion. Okay, referral to bereavement services from somebody's phone, TLC.
Okay. Anything else? Can you see how there's so much that you could write about? Now, you've seen the totality of this nursing record. So what I want you to think about is if this was a staff nurse in your department that has made these notes, because this is the sort of level that this was written at. On a scale from 1 to 10, I'd be interested to know how you feel that one, this individual had captured what they'd been going on. And the second mark of what I want to know is how it will compare to the notes that are made in your department. And then I want to know, are they similar, are they better, or are they much poorer? So if you could put those comments into the comments box, that would be great. Are we seeing anything coming up?
Andrea, poorer.
Okay. And on a scale from 1 to 10, how much would you give?
Elizabeth, this is better than in our department. Neuro-obs are poorly done and documentation has become a tick box exercise.
Okay.
Alison, there's nothing documented about any personal care.
What do you mean by personal care? Because it says here she's been incontinent of urine, she's been washed and a gown has changed, she's had mouth washes, she's been made comfortable. What other care would you want documented?
Chris, much more comprehensive than in my department. I think they have captured the event 7 out of 10. Alison, I missed that, sorry. Gillian, better than our department, often lack of any nursing documentation. Sarah, I think there is fair detail there. Working in a busy environment, you can't write streams, main events captured. Galaxy phone, initial assessment, A, B, C, D, E. From an iPhone, we use checklists and risk documents. From K, 7 out of 10. I think there is more than in the department I presently work in, but less than my last. Caroline, these notes 6 to 7 out of 10. Notes are good, but too many abbreviations. Some of the wording is a bit vague, similar to our department. Mary, similar. We would also document care bundles and fall water low assessments. Dorian, concise and captures main info.
Okay, that's great. Now, similar to what they do on Blue Peter, I've done one, made one up already.
Jean, similar comments, captures main event.
Okay.
Hannah, it's better than most documentation or department 8 out of 10. Some long periods without documentation.
Okay.
Emma, good documentation, changes clearly documented.
Okay. So we've got a mix of reviews there, haven't we? Some thinking it's far better than in their own department, some thinking that it's reasonable what's been documented, and some thinking there isn't enough what's documented. So I suppose if you are doing a case review on one of your own patients, then those are the sort of things that you need to consider. So this is one that I did earlier. And look, you've picked up tonight an awful lot more than I have within this, but I've just tried to give you a sample. And when you're doing one of these case reviews, it doesn't mean you've got to pick up every single point you can, but the more you pick up, then the more comprehensive it is and the more hits you'll have against your index. Okay? So one of the main things that we've got to make sure is that we write what annotated note it is, so it's clearly identified, and the date is all important. The other thing that's important is that if you have got anybody else's name or their signature within something that you're submitting, you really should have a list of permissions to allow you to do that in any portfolio. So you need something there. Can everybody read the comments that I've put in? And here you will see, for example, that I have said that this evidence comes from a reference, and I'll show you the references after. Can you see how you can start to go into the anatomy and physiology there? Are there any comments on this with the annotated note?
Hey Judith.
Yeah.
While it's quiet for a minute, I thought I would just say this is a really great transition from ENP minor injuries towards more advanced practice. And I think in some areas, paperwork might be done separately for the nursing documentation, and it's whether or not we include everything or just the bits that the student has signed.
Yeah. Yes, definitely. Any comments coming up?
Not at the moment.
Do people like this way of annotating a note rather than having to write a long case review?
Hannah says yes. Kay, good example of good way of annotating notes. Tanya, what does a permissions table look like? Sam, yes, it's clear. Alison, yes.
Okay, it would just be a list of people that you would put in, and you would say on the top, the following individuals give permission for their names and signature to appear in my portfolio, and then you would make sure you've got their printed name and their signature, and you'd have a date. So that way you've covered it. In some ways, if you were working in a department, and I know some of your departments are massive, then it might be worth going round, and the people whose note you're likely to pick up, just get them to sign, because I'm not sure if people know they're anonymised and you might have got a signature in there, you're very unlikely to be able to identify the patient just from your signature.
From Jenna, much more succinct with less chance of rambling in a case review.
Okay. Now, if you were writing up a case review, what I'd say is that this is what you should be putting in your case review anyway. It shouldn't be rambling. It's almost what I call staccato sentences, which is where they're very succinct and you get into the point. So you don't get much for describing something. You will get much more for explaining something, so taking it deeper. And that's what we're looking for, not the description. The description is a lower level work. We want to know the rationale for why you're doing things, why it's important to look at, shall we say, the vital signs, what you're actually looking for, that you will recognize it.
Leanne agrees, a very efficient and direct method.
Yeah. Okay, let's go down to the next sheet. And here we've picked up on the tetanus, haven't we? And you could have, in this case, discussed whether she had dementia, and if she had dementia, how you may have used the Abbey pain score to assess her pain. So you could have pulled that in.
From Galaxy Phone, past medical history.
Yeah. As I've said, there's probably as much as I've pulled out, there's probably double the amount of stuff you could have put into this if you'd wanted to.
Okay, social history.
Yeah. All the things that you're picking up are really relevant. And you've got to remember, if somebody comes into our departments and inspects our notes, then those are the types of things that they will be looking at. Bless you, Annie.
Mary, we use 4AT in 75 and new confusion.
Use what, sorry?
4AT.
What's 4AT?
A delirium screen.
Oh, right, okay. That's a new one. I haven't heard of that one.
Galaxy Phone, resuscitators.
Okay,
Emma, we use 4AT for delirium screen.
okay.
So there are others. We use ATM4, which is probably very similar, just with a different name.
Okay, Annie, thank you. Go into the last slide. Sorry, John, you were breaking up now. What did you say?
Alison asks, will we have access to see the slides again after the session? It would be very helpful.
Yes, you will. We'll put them on the web.
I'll email everyone after the session once they're available so you can see
Yeah.
them.
Okay. Okay, what's your overall, give me some overall comments on how you feel, how well this nurse did in the review and reflection. Any comments coming through?
Yeah.
Not yet.
Gillian really assessed overall, provide good supporting evidence. Caroline, I think she reflected really well. The notes incorporate reflection, anatomy and physiology and relevant references. Excellent learning.
John, you're frozen.
Hello?
No, you're okay now.
Hannah, overall very good. Galaxy, family reassurance and support. Chris, I think they did well. Good points noted, but also learning points identified. For an iPhone, adequate, I would pass.
Great. Fab. Let me take you down one more page now and you can see the references. Okay. So from those number ones or number twos or whatever, here are the references that I pulled in. And obviously these will be on the slide should you want them. So are there any questions, comments or concerns? How well do you think this session went? Did you get something out of it? Or is
Hannah,
it?
very helpful. Thank you, Chris. None from me.
Okay.
Galaxy Phone, one pathway for Wales.
Okay.
Okay, it was good to talk through and learn about different delirium assessments.
Yeah.
Gillian, very helpful. Mary, very helpful. Thank you and useful. The iPhone, Ken, does it map to?
Right, that's what I'm going to, the next part of this is going to be taking you through indexing and mapping. So
Chris,
we'll be
good
doing
session.
that. I just wanted, because the session's in two parts, I just wanted to make sure that we'd covered what you wanted in this.
Tanya, helpful, just putting into practice. Andrea, thank you. Sam, this is my first and I enjoyed it and helped me on my way to start nursing. Alison, useful. Sarah, thank you.
Not just in its entirety.
Yeah, just attach. Please see 10,000 words for evidence.
Calm down, Sam. I gotta read it.
Hey, Owen. Oh, I thought it was you, Emma, on your phone.
Yes, it's me.
I said, is that you?
Okay,
Good try,
is
Sam.
everybody back? Everybody back. Shall we have a go at the next bit then?
At 29.
Okay.
Yeah.
Okay, let me see what I need to get into. Now, this is something that I hope you can see it all. The competencies that are on our website, we have been developing into a qualification, so that not only will you get being able to be assessed and be able to hold the title of associate or member or fellow, you'll also be able to get academic credits for your portfolio. So what we had to do was we had to revise the documents that are on the website and write them as learning outcomes, which are the LO, you see, and then as assessment criteria. So this is where you get clever at your indexing now. So this will be the live document. I don't think we'll have many changes to it for care of the adults and older people. So obviously, as the lady was in her 80s, then this is, you can gain, you can use the evidence against this. But similarly, you will be able to do exactly the same process as we've got here, to look at the core competencies, the trauma competencies, the major ones, the minor trauma competencies. I don't think that they would, you might be able to use some of them for pre-hospital care, depends how you've written it, all right? So what I want to do now is to take you through, and what we said that that's the last document was, it was annotated note 6, wasn't it? Yeah. So thinking back on what's contained in that, do you think that you could have part or full competence signed off against AC 1.1? So again, if you put it in the sidebar of what you think, then we can take a consensus. I'm just cutting and pasting so that I can make it easier as I go along. So does it meet part or full of evidence? Is there anything in there that shows or discusses communication skills to rapidly form an effective therapeutic relationship?
Jenna says yes. Gillian, yes, communicated with patient and family. Caroline, yes, because there were notes about discussing case with family.
Okay, so we can put it in. Now, does that mean that it is complete, or will it go part towards it?
And Case said there was evidence of communication with family.
Yeah, I think that would be part, wouldn't it? Rather than full.
I don't see there's enough to demonstrate, so part toward.
Yeah, okay. And I think if you were developing this for yourself, if you write part or full, you'll know whether you need to go back and gain more evidence before you submit it. Yeah? So let's look at AC 1.2 then. Is there evidence there for the use of distracting techniques with patients with a variety of complaints? So were any distracting techniques used?
Jenna, no.
No. Okay, so we can't use that one in there. So the next one, was there anything in there that summarized the normal function of anatomy and physiology for adults and older people?
Sam says yes.
Okay, full or part?
Jenna says part.
Okay.
I would say partly full, because they go into the anatomy of your older adult, but they also say about intracranial pressure and heart rate raises, etc.
Yes, so they do partly meet it, don't they?
Okay.
Because there's the anatomy and physiology of the body is vast, and if you come on to the next part now, you will see that there's a list of things here. So summarize the effects of aging and disease process for each of the body systems. So which of these have we got? Well, obviously the nervous system, we've got a part in there, haven't we? do we cover any of the others in there?
If you're working to this criteria, you could have included some of the other parts to cover this one question.
Yes, so which ones could you have picked up on?
You could have said about the circulatory system with the
Yeah.
increased heart rate as well.
Yeah, yes, and certainly because somebody mentioned about the patient requiring the ECG and had she collapsed, so it could possibly have been a cardiac event. And also, I think she had, didn't she have AF?
Yeah, she had AF, and I think this shows the importance of reading your criteria before writing your piece of work, so you cover as much as possible in your work.
Yeah, exactly. Okay,
Skin.
so you could have pulled out a bit more. Skin.
Gillian, respiratory, cardiac, skin.
Where have I got the skin there? I can't see for looking at it. Okay. No. Where have I missed out skin there? I have. I need to add skin to that bit, but yes. Okay. If we go down, pathophysiology and pathopsychology of the following disease processes. Reduced conscious level. Any other comments coming up, John?
Not yet.
Neurological.
Neurological. That's neurogenic, as in shock.
I was quick reading, sorry.
Yeah.
Kay's thromboembolic talks about anticoag.
Yeah.
And Chris had met reduced conscious level. Yeah, you've got that in there.
Yeah. Where's the throat? Oh, there we are. I got it. I should really move over. Okay. Somebody was mentioning airway management as well. So had you developed this further and said that her airway was at risk, especially with, well, we did, didn't we? Because she dropped her GCS to 8. So we did mention her airway, didn't we? So it covers that part as well. Okay. So here we go. Explain the pathophysiological responses of aging to the following acute presentations. I've forgotten to list them, sorry. I thought I picked up everything. And this is undertake a focused assessment of the physiological, psychological, social and spiritual needs of an adult with each of the presentations listed in 1.3.
Hannah says it's titled non-traumatic, question mark. Chris, there was little description or discussion ref pathophysiology in the comments.
Okay. Even if it's a lot of the assessment of neurological, it doesn't make that much difference whether it's from trauma or not. It's the same principles that would apply. It's the mechanisms of injury that would be different there. I love the dog, Sam. Yeah. Where did you see the non-traumatic bit in the title of the thing above? You can still use your literature to go across, even though it's titled non-traumatic. So would we be happy to sign off 3.1 here? Anything coming in?
Gillian, part to sign off. Tanya, yes. Kay, discuss spiritual support.
Okay. Tell you what, I'm going to do part and then I can change it to full. It might be easier. Okay, so the next one then, if we go down to 3.2. Undertake and document a focused assessment for an older adult requiring emergency care. So can we cover off any of these?
I mean, as she's come in with a falls to the ED department, a falls assessment should have been undertaken. We did change her into a gown, to which we'd be looking for other injuries and pressure ulcers, so we could do the risk assessment for pressure ulcer risk. We've done GCS as well.
The falls assessment I would see as something that isn't your first line. It definitely needs to be done before she's discharged and to check her out. But if she's that sick when she comes in that she starts deteriorating, you're probably not going to worry that much at that point about her falls assessment. But definitely the pressure risk is going to be great, isn't it?
Gillian says pressure assessment. Chris says falls and pressure ulcer.
Yeah.
Alison says, Elizabeth, there was a broad assessment of some of these, but not a focused assessment. Cognitive, functional, frailty missed.
Okay. And sometimes, you know, it would be appropriate that some of these are not done when they come in and they're that sick. You don't, you know, yeah.
Yes, you would get more baseline. Gillian, some social assessment done.
There was some, okay.
From a phone, Adele's assessment?
Sorry?
Not sure what that meant. Adele's
Right.
assessment.
Adele's assessment. Right.
Oh, dolls.
Dolls. Okay.
Okay. It was documented that it was new reduced GCS, which would suggest cognitive had been considered.
Okay. Let's go on that one then. Fine. So we, off one case review, we're getting quite a few hits, aren't we? So, understand the assessment tools to manage a range of presentations. So I suppose we looked at GCS here, didn't we? Is there anything else we can say that we did?
Was the GCS critically analysed? Why we use GCS? For example, they should have, in my opinion, used GCS compared to AVPU maybe, and say why we use GCS instead to get this marked off.
Yes, so it could be part met, couldn't it? Because they've been talking about GCS. Yeah. And it would be this one would be far more than just neuro. So it again will be part med because you're looking back to the 1.3 which listed all of those different complaints.
Okay, it was documented that there was new GCS, which would suggest cognitive had been considered. Triage tool. Leanne, we mentioned 480 and Abby Payne score for the assessment.
Yeah. So we've got quite a few things marked off in there.
Chris, 8E assessment.
So what number are we on now? Are we on AC 4.2 or AC 4.1 still? Okay. Anything here? Assessment, medical and surgical? Probably not because she didn't have
Chris,
surgery.
8E assessment could be used for both.
Okay, there we go then. For prioritising care.
Kay says triage would cover both.
Yeah, okay. So if we took the explanation of the tools and why the tools were needed or needed to be modified because she was older. So like we were saying with the Glasgow Coma Scale and the frequency of the observations, you probably want to do them for a bit longer in an older person than you would the standard for what's documented in the NICE head injury guidance. Yeah, so we can put a mark in the box there, yeah? Okay, life-threatening presentations and how to manage them. Did we do any of these? Definitely not an ectopic.
Hannah King, SAH. Chris says no.
Okay. Did we mention SAH in the Now you could have gone down the line of SAH, couldn't you? Because you could say that if she'd collapsed and lost consciousness, but she'd remained unconscious, then one of the differential diagnoses could have been a Sebarak. But it depends on what you pull out of the case and what you discuss. Okay, let's have a look at Learning Outcome 7 then. It's 7.1. Analyse the variance between adult and older people in relation to life-threatening presentations and the requirement for immediate intervention. So the thromboembolus we picked out last time, didn't we? Anything else we can discuss here?
Could you mention about airway and breathing with if the GCS would have dropped?
Yeah, okay. Okay.
Gillian, airway and breathing with seizure. Chris, shock hemorrhage.
Shock hemorrhage, okay. Hypovolemia rather than dehydration, yeah? Can we put anything in 8.1?
Hypovolemia. Galaxy A20.
What, in 8.1? Emotional and psychological reactions.
I think that's from up above the hypovolemia comment.
All right. Okay.
Dania, family were supported. Gillian, no mention of family reaction.
Okay.
Chris, 8.1, yes. Discussion, ref deterioration and operability. Kay's iPad, family support.
Yeah, and they did say the family said thank you to them at the end, and that the family were distraught, didn't they? Or distressed.
S, thought family were upset.
Yeah, okay. 9.1. Anything on 9.1, we can put something in the
Tanya,
box.
morphine, an antiemetic.
Anti-
K, analgesia and antiemetics given.
Okay. So which one does that hit then? Drug calculation and administration.
Chris, if INR came back raised, could discuss too much medication.
Yeah.
Gillian, IV meds and rectal is given. Tanya says IV. Someone's iPhone, first 2 boxes, yes. Hannah King, root, K, IV administration.
Yeah.
Another phone, patients for administration.
So we didn't mention anything about giving too much. So if we had talked about why we needed to titrate the dose, then you could have brought that in there. The interactions between medicines and herbs, always important when taking a drug history that you, Jeanette, I can see is laughing at this point. You need to ask about, do they take any herbal remedies? And St. John's wort comes to mind.
I'm laughing as well.
That seems like a pretty tricky box to fill in. So St. John's Wort would be the ideal case to get that one like ticked off if you're trying to get it cleared.
Yeah. Or the other one would be garlic.
Oh, if you don't mind me asking, garlic interacts with?
Well, if you take enough garlic, it's not the interaction, it acts as an anticoagulant.
Okay, thank you.
Yeah. There's an awful lot of that herbs react with everything.
Is that
Black
like-
cosh, I think, drops your blood pressure.
That like eating too many polos gives you the squirts?
Probably. But only if they're the ones that are,
Low sugar.
yeah.
Okay.
I was thinking cannabis myself.
Yeah.
Warfarin related, grapefruit reacts with warfarin from Tanya.
Yeah. So there were quite a lot there that we could have pulled out in that if we'd written a bit more about it. And Annie was right, the illicit drugs, although some of them are legal now, aren't they? The cannabis oils and things. Okay, critically evaluate the difference in medicine management for older people in the emergency department. Did we do any of that?
Any food with high amounts of vitamin K, leafy green veg increases uptake of warfarin.
Okay, but is that specific to the older person? This is about the difference in medicines for the older person to the younger adult.
You could discuss about a smaller dose of morphine may have been given because of respiratory distress in the older people.
Yeah, you certainly could have done. So we can put it in there. Okay.
I think from the next section, Hannah has said no.
Okay, no variance. Okay. So 10.1.
Okay, I suppose some older people may have a better diet.
Yes. Okay, we could have mentioned that. Critically evaluate care delivery and care plans. Can we put something in there that they've evaluated the care that they delivered in the plan? They mentioned it, didn't they? And they identified what they'd missed. So could this be part? Anything coming through?
Tanya says yes. Chris, they did identify learning points, so partly achieved.
Okay. The variance for older people versus adults.
I think with the current pandemic, they're doing the escalation of care for every patient that comes in. So that would come under looking at a younger patient versus an older patient on their chance of survival with the different conditions they come in with. So it would be under the escalation of care, maybe partly completed.
And I also think that they, when they were discussing the older person whose brain had atrophied, there was more room for them to have space around their brain. So when they bled, you didn't notice it until it was a later sign. I think this would cover some of that, wouldn't it? And that's why you needed the vital signs recorded longer or over a longer period in the older person. Yeah.
Chris says no. From an iPhone, yes. Considers extremes of age, risk assessments, falls, pressure care, ECG, A&P changes.
Okay.
From a phone, yes.
Explain how to assess and why to assess pupil size and reaction. There was something in there about that, wasn't there? Yeah.
Yes,
Visual
there
acuity.
was.
Yeah, visual acuity we didn't, did we? So what about 11.2?
Caroline coma scales.
Yeah. We certainly discussed ECG readings, didn't we? And the need for them. Vital signs.
Julian says vital signs. Chris says most of that list is partly met. iPhone, BM, vitals.
Yeah, I don't know whether we actually mentioned these here.
GCS and neuro.
Mentioned, not, well, somebody mentioned limb assessment because they said they'd need to do a head to foot to make sure she hadn't injured anything else. Urine output we didn't mention, or urinalysis specifically, certainly not a pregnancy test. And BM we mentioned.
PARL, but don't think it mentioned the importance of this in relation to a head injury.
Yeah.
Galaxy phone blood glucose from an iPhone would have done a gas.
Yes, okay. Oops, I gone too far. So, evaluate the variance in monitoring or care, point of care selection between older people and the younger ones. Did in relation to the collapse and things with the ECG, didn't we? Okay, so partly would go towards that. Spiritual, cultural. Any comments coming through?
Yes.
Yeah. External influences.
Arranged. They mentioned spiritual and less rights.
Okay. Can we put anything in LO13?
For ambulance, what do you mean external influences?
Policies and practices. It could be the other thing that had a big impact on this person was the neuro team, wasn't it, at a hospital where they said they wouldn't take her. Now, I've certainly seen it, and you may have as well, where some of the patients that we feel, oh my goodness, they really should have gone, I don't understand why they didn't take them. That could be well a point that you could discuss in one of these cases.
Okay, no beds available on the ward.
Yeah. Yeah. Good point, Kay. So we could have put something in there. What about the policies and practices, did we, or guidelines? We mentioned the nice head injury guidelines.
Chris, discuss a clinical breach for these boxes. Galaxy A20, long stay in eating trolley, no beds.
Yeah.
iPhone lots referred to. IK discussed nice and Orchem, Gillian nice guideline.
Yeah. Okay.
Recently.
Legal and safeguarding. We certainly mentioned that one, didn't we? Types of abuse we didn't really go into, did we? And we didn't talk about the appropriate interventions. So we're down to 16, I think, now. Effective communication strategies.
You talked about different pain scales, using a different type of pain scale with a person with a low G.
Yeah. Certainly we interacted with family members, didn't we? And mentioned that. Okay, guys. I'm going to call it a halt there because I want to have some general discussion now and some other ideas here. So we'll stop going through this at the moment. So it would be nice to know, sorry, the next part you would then do is you'd pick up the other units that you feel you could get credits for, and you'll be doing exactly the same. So for every piece of evidence that you've got, you would be doing the same. You'd be going against these indexes to map what you've actually got and what you need. Can you see how one piece of evidence can meet so many things depending on how you develop it? Yeah. So what I would like to know is, what are your thoughts on this session? Have you done annotated notes before? Do you feel it's a good way to move forward? Yeah.
I think this method of annotating notes is a lot more easier to fit in with a work lifestyle. You could possibly find more evidence whilst you're actually working and use it, rather than having to sit down and write a massive piece of literature. It's much more, you could do it over a course of 4 or 5 nights and not lose your place.
Yes.
I've had a few comments, but try it after the session. Not done annotated notes before, so I found it useful. Yes, easy to build on. Not done them before, but I'll give it a go. Annotated notes would have been good when I did my EMP course. fresh exposure to it feels as if it would be quicker and easier, much easier to link to various outcomes. Yes, like a pathway.
Yeah. And to be honest, I think the secret is getting to know what you're trying to demonstrate. So if you know what your index is, or what your program is, what your qualification is, then it makes it much easier where you think, oh yes, if I put this in here, then I am able to get the more signed off for it. But remember that all of this needs to be succinct and not written, because you don't get anything for describing things. It's about rationalizing why you do something and why you choose A over B, or why a certain aspect would be inappropriate for this patient. It's that we're looking for.
Definitely engage, as writing essays can be daunting for some.
Yeah, exactly.
Absolutely. And I think it can be part of a bundle of evidence.
Yes.
So your annotated note can come alongside. You could pick up a specific part of your annotated notes and do a little spider diagram, or an audio case-based discussion with your assessor. So it can make up a nice little succinct bundle, which can be sometimes just as robust as writing rafts and rafts of written word.
That's right. Jeanette, do you want to come in and say anything? She's still here.
Claire loves a spider diagram, apparently.
Oh.
I've been taught by the best, Judith.
I always thought it was Judith loved a spider diagram.
It's me. We'll do spider diagrams in a different one.
You've rubbed off on me, Judith. You've rubbed off on me.
Yeah, I agree. The spider diagrams are also a very good way of cutting down the volume of notes, but still making the same massive impact.
We'll do that in a different session. John, do you want to say anything? You've assessed people's portfolios that have gone along these lines.
Yeah, I quite like an annotated note because it feels more personal to me than reading an assignment or reading an essay. I think you pick more out of it when you're going through your notes. Okay. And there's less chance of waffling, well, I've noticed.
And remember, you can annotate anything. You can annotate a diagram. So you could use a diagram that's related to A and P, and annotate that and apply it to a case. So I know this might not be particularly relevant for AFEN, but I know in the EMP world you can annotate an X-ray. There's no reason why that you can't, annotate other pieces of evidence.
Or an ECG you've looked at, or
yeah, an ECG. An ECG is a good one. Yeah.
Would you be able to annotate a risk assessment as well?
Yes.
That's a good one. Yeah, it's a really good.
But just remember that whatever you're annotating, you need to make a reference to it. So you've got a reference list. And if you're annotating something and it's related to a patient you've looked after, it's always good to have a copy of an anonymized patient record to put it together with it.
You could take anything apart. You could take a skin bundle you've done apart and take it to pieces and get lots of information from it.
Yeah.
And I know we have people from all over the country here, but you keep mentioning referencing. Which reference system do you use?
It really doesn't matter as long as you reference it. It probably you would use a mixture. It's like the numeric one works really well if you use an annotated notes, because otherwise your names would be in it and would be very long. So, doing it for the faculty or doing it for Agorid, which is our accrediting body then, or is going to be, they're not precious about that. It's as long as you don't plagiarize, that's the main thing.
I think it's really, Judith alluded to this earlier as well. Remember, a lot of people are scared of technology and putting it, using text box, etc. It's a great skill to develop. But, if you're beginning this, you may want to just, use the handwritten word, and then develop your IT skills. Just because it's handwritten, as long as it's legible, doesn't mean that it's any less value. I mean, obviously, there's some of us like me that get, like it all nicely in electronic format, but that's very much dependent upon you and your choice.
And I've seen some of the most amazing portfolios where the notes are annotated, they by hand, and then they've taken a pencil and coloured in some of the boxes.
Yeah.
And I have to admit, I love the stuff that you see on YouTube, where you've got somebody who's drawing and you're doing arrows and they're doing goodness knows what to explain what they're doing. One of the YouTubes that I suggested that you watch was about that, where they were drawing the subdural bleed. Yeah. So there's no reason why you couldn't develop something like that.
So I should expect that from you next time, Judith?
Of course. I wish I could draw. Any other comments or any questions or?
Jenna, issues are good. Wish I could draw like that. I think we all could. Can't draw a straight line. Is there scope to include some personal reflection notes on the practitioner's thoughts and feelings when dealing with?
Yes.
Potentially discussing cases.
As long as you make the evidence pertinent to what you're trying to demonstrate, the only one who will stop you doing it is yourself. You can use anything as long as you can make it pertinent to what you're trying to demonstrate. There isn't any limit, really. I mean, when the competencies come out, for example, the adult ones, we will have a range where we will say, we want you to have, for example, 6 case reviews, which we'd want 2 of them written up as a case review, 2 written up as an annotated note, and 2 further could be either. All right. We will say, we need you to have so many mini clinical examinations of somebody observing you with a patient and signing you off for it. We may say that we want to see you demonstrate certain procedural skills. So there will be some prerequisite bits that you have to have, but then we haven't said what the maximum is. All we've stipulated is what the minimum is. If we were, we are planning on running a program this year for the associate level. Who would be interested in doing that as a learner? Sam, obviously.
Sam, many screens, I'm going to call you from now on.
Yeah.
Tanya
said she would. Great.
Self-maintaining
Gillian
resilience.
Molly, yes. Okay.
Chris, he says, what would you get? And you, Gillian K, yes.
Great. Okay.
Do you want to explain the qualification a little bit, Judith?
In which way do you mean the qualification?
There's a qualification linked to this. What would you get?
Okay, hold on. I probably can do it through screen sharing again. Give me 2 seconds.
Screen envy now. Screens here.
You're going to get some more screens tomorrow, aren't you, John?
I'm thinking of connecting up the TV.
I'd like to get mine on my iPad.
Leanne Moore, I'm a little bit disappointed you haven't got your Wham background on.
Is this the slide that you meant, John?
Yeah. I
As
think
in the
that can help to explain the
qualification.
qualification.
Okay.
Yes.
This breaks it down a bit into the, actually we can go to the slide before. I don't know if I shared this last time. For the faculty, what we've got are, we have got the associate nurse level, which is the first step on the ladder really. And the white parts of it are the flower. It goes through, it permeates through everything. So there are some specific competencies where if you achieve these, then our view is that you've achieved them, and you probably don't need to demonstrate them in the adult or some of the others parts of it, but you may well get the same evidence covers everything. You've got cause at member and you've got cause at fellow. So they are, as I said, like the flower in the cake. You then go from being an associate to a member. Now, member level is sister charge nurse, it is your AMPs, your EMPs, and then you come out to fellow, who are your experts, so it would be your consultants. You've then got 8 different units. So you've got your emergency care of the adult and the older people. Now we recognise that you can't separate those out. So those will be one unit. You've then got the child and young person. We've changed minor injuries to just calling it injuries because there's no such thing as a minor injury. Yeah, because it can still have life changing effects. There's major trauma, psychological needs of the patient, and that includes mental health. And then there's pre-hospital care and major incident planning. Now, we recognise that from when we first started this, things have moved on. And you could, at associate and member, you definitely need to acquire core. You need an age-related one, and you need your psychological care. And then you can choose one of the others. But as you get more senior, so as you get to expert, then you should be able to demonstrate your MFEN competencies, and you would have your core, and you'd pick up one other. All right. Now, if you look at the cost of this, and really and truly, it depends where you work in and whether the hospital or the country you're working in provides you with education anyway, then it's an awful lot cheaper than a university would be. For example, we run a program for emergency nurse practitioners, and that works out to about £550 for 180 credits at level 7, which is the equivalent of a master's. Okay, so there's a huge variation, and the beauty of this is that you can pick up single units. You wouldn't get the AFEN or the MFEN or the FN qualification, but you pick up single units. You could pay for them as you go in for each unit as you submit it until you get your award. There's also the opportunity for individuals who are already experienced to pick up single units without going for the award, of the full award. And there isn't anything to say somebody can't who's already experienced. They don't necessarily need to have their associate before they go on to their member. They could just start working on the member competencies if they already feel that they have gained or they've got all the competencies for the associate. Anything to add, guys?
Chris has asked, I work in a local emergency department. We don't take major trauma. Would this be a hindrance?
No, because you can pick up the other competencies that are there. So you only need to choose one out of here. So you will see major trauma is you can exclude that, and you could pick up the child and young person, or you could pick up on, if you do the minor injuries in the unit rather than major trauma, it certainly wouldn't be a hindrance. Yeah.
If you were, say, doing the associate level, say, minor injury,
Yeah.
and then you wanted to go for the member level on, say, major incident or one of the others, just that everyone can remember, could you do that?
Yeah.
And then use that later on?
Yes.
So instead of doing, say, the minor injuries at the associate level, if you've already got that level, I should imagine it would be worth you doing it in the higher level to go towards a new qualification.
Yeah, it depends what you want to do, doesn't it really? If you picked up minor injuries at AFEN and you want to become an emergency nurse practitioner where you're dealing with minor injuries, then having the AFEN minor injuries would be of huge benefit to you. But we've got individuals now who are, they've got a bit more work to do because they haven't got those prerequisite skills, but they are still demonstrating and achieving their EMP qualification without that minor injury experience. And to be honest with you, things have changed in the last 20 years, whereas emergency nurses coming through always had minor injuries experience, but it tends to be now that a lot of the care for more junior staff is around the majors area and resus, and very little time is spent in the minors area or developing the minor injury skills and treatments that you would have had years ago. So that's one of the reasons why we've developed the framework as we had and divvied up what you need to be at whatever level, is because things have changed and people don't get the experience that they used to.
Yeah, I think I'm very lucky in my health board because we have all of the areas in locality, and I know in my A&E you actually travel from one location to the next, so you get experience everywhere.
Yes, you are, Sam.
And I think, Judith, and correct me if I'm wrong, guys, everybody across the South Wales corridor certainly is looking at the major trauma competencies for the areas where they got them, and they would transfer beautifully to this.
We've had a request for the slides for requirements for qualification as well as the other slides. And Chris has said he's just about to leave.
Okay, thanks,
I will
Chris.
send everyone an email later with a feedback form for this session.
Okay.
Okay, our minors go to UCC, so our nurses don't get that exposure.
Yeah, and that's fine.
Yeah, that's absolutely fine, isn't it? Because as you know, Judith says, we acknowledge that emergency care is changing and evolving, and you know, you don't get the opportunity to work in all areas now. So that's why I think the competencies have evolved and changed, because emergency care is changing as well. That's why they're flexible.
Yeah. Any other comments or?
I've just sent that feedback form to everyone. If you could kindly complete that, you will get a certificate sent to you afterwards.
Meg. Sorry, that's my dog. It's not me barking, honestly.
That's
Okay.
Judith's dog, Meg, saying your time's up, Judith. Time's up.
Yeah. Okay. Thank you all for participating tonight. We plan to have another one in it's about 3 or 4 weeks' time, and we probably won't be doing them free. We've given a couple free, but it's free to members, and then I think it'll be about £3.50 every time. So if people are interested, then they're more than welcome in whichever form that we do them. So I hope you've enjoyed tonight. Yeah. Okay. Good night.